Welcome to the Her Health Podcast, transforming health for women and girls at risk, where we empower women and girls to take charge of their health and well-being. Join us as we shine a spotlight on issues affecting women and girls' health and explore ways to create positive change. Get ready to be inspired and empowered as we discuss health, advocacy, and empowerment for women and girls at risk. Please be advised that this podcast may cover sensitive topics such as gendered violence. We understand that these discussions can be difficult to listen to. If you feel uncomfortable or need support, we encourage you to prioritize your well-being. Consider exploring our other podcasts if these topics are triggering for you. Resources can be found in the description.
So good day, everyone. Welcome to the Her Health Podcast. I'm your host, Alexandria Lazocek, and today we're joined by Dr. Vedam, Professor of Midwifery at the University of British Columbia, lead investigator of the Birthplace Lab, and one of the most influential figures in global perinatal health equity. Over 40 years as a clinician-scientist, she has developed the tools that now measure respect, autonomy, and mistreatment in childbirth in 64 countries. Her team's work won the National Quality Forum Innovation Prize in 2017. She leads the CIHR-funded Justice and Equity in Perinatal Services Hub, and in 2025 received the Lifetime Visionary Award from the American College of Nurse-Midwives. Today's conversation builds on her webinar, We Have Met the Enemy, and They Are Us. How do pregnant people define quality and safety? A title that itself is bold, because the evidence is clear. In perinatal care, the greatest threats to safety and quality are not random or accidental. They are structural, and they are patterned, and they fall hardest on Black and Indigenous peoples. Today, we're going to talk about what the research shows and what accountability looks like and what providers can actually do. So thank you so much for joining me today.
Thank you for having me and for that kind introduction.
Absolutely. To get started, your webinar title, We Have Met the Enemy and They Are Us, is direct indicators of providers. And what does the evidence actually tell us, and about how provider interactions and the health system design affect the safety and well-being of pregnant people?
Well, first I will say I don't think that the us is just providers. I think the us is the entire health system, the way the system is designed to advantage certain communities and groups and disadvantage others. And there are, as you know, many people have been studying structural determinants of health, and for years have been talking about that. I think it has been linked to adverse outcomes, but without understanding. Basically, until recently, those determinants of health were all assigned to the person, as far as whether someone was poor or had lived with a disability or, had substance use in their history or incarceration, and the sources of adverse outcomes were linked to whether or not those people sought care, accessed care, showed up for care, whether or not they followed directions or did what the health system wanted to do, whether or not they fit into the structure that we've set up as an entire. So, providers are just one cog in the wheel, as we would say. There are, whole systems. There are appointment schedules. There are, where the areas of service are located. What do those services look like? How much time do you have when you try and access care? Do you have to go somewhere, or do they come to you? Are they close to your community? Do you have transportation? Can you meet with someone who understands your cultural context and who respects the ways of knowing and healing and well-being that your community comes? So I think all of those things go into that us. There is I think what we're talking about is shifting the frame to, it's that blame the victim thing, right? What can we do better to support individuals and families to thrive?
Absolutely. Thank you so much for diving in that it's not just particular providers or healthcare, it's a system, and it even is beyond the healthcare system of just it's linked to people, how they get into healthcare in the first place and the ways of knowing. Thank you so much for diving into that and giving us more of a good like understanding of who the MD is and how it impacts everyone. I appreciate it. And you spent the last 40 years designing and developing tools that measure something that the health system rarely names. So, disrespect, loss of autonomy, and mistreatment in childbirth. Why did those measures need to be created? And who wasn't being accounted before they existed?
Well, I would say that it was really in 2016 that the World Health Organization finally started to recognize that experience of care was as important as whether or not you had clean water or access to providers um, or access to medications. That, those things are very important if you for how we've evolved our understanding of at least allopathic medicine, reacts to and offers solutions and treatment things. What even before then, visionaries like Paul Farmer started to say it's not, enough to say we have these great new TB drugs. If the drugs have to be given on such a regular basis that people have to come to clinic from distances across rivers that are overflowing or bridges that are broken and roads that don't work. Because if we can't structurally make the healthcare and health center accessible, then they're not going to come on a regular basis. Then we'll get resistant strains, or we won't, the treatments that we have won't work. So you can't just fix it with a single solution like a medication. You have to look at the whole context of care. So he did amazing work towards that end. And then following on that, there was a lot of talk about experience of care, first around disrespectful and mistreatment, which the WHO was examining because there had been reports of abusive care, discriminatory care, discriminatory access to care, and they realize that if people don't feel respected, they're not going to come to care. So that's the first, you can't even offer the services if they don't trust. And if we don't respect traditional healers who might accompany them or might start the care in the community, then we won't get full information when they come to us. What other types of treatments, herbs, things that they've tried, how long has it been going on, what's the skill of that traditional provider and experience, or did they have anybody caring for them? And so if you don't have respect both between the receiving providers, whether it's the person who's the transport person, the person who receives you at the door, and I'm really broadening it to just the individual provider patient interaction, because we know in the global context, you can have people have to pay bribes just to get a bed, have to be told to turn over their cash incentives that they were given to come to the hospital, say, to give birth, but turn it over if they want to be able to be seen. So there's a lot of, and that those barriers are being done by orderlies or people who are triaging in very overcrowded hospitals. So we know in middle resource countries like Hungary, where there's a accepted sort of under the table payment, informal payments they call them, so that you can get a known provider. You can guarantee that the person and then we know that people who give birth really want to have the trust and know their provider. And so this is really happening all over the world. And I think it's not necessarily been accepted in high resource countries where we're supposed to have the best care systems and technology and modern medicine and enough doctors. But what we understand from our research is that disrespect and abuse or respectful care happens all over the world. And there are certain common characteristics of both about how people experience it and how it links to outcomes. In California, they showed that delays to care, which occur when people don't listen. Someone says, I'm bleeding, or I don't feel well, or something's not right, and they're sort of reassured and dismissed or not listened to, and then that delay whether you are in sub-Saharan Africa or you are in Canada, can lead to serious problems if you miss or don't treat someone early enough. And so the types of respect and disrespect might change. We understand this concept of respect to be many different domains. It might be the individual interaction between you and a provider. It might be whether or not how you book appointments, whether or not they have the kind of resources or comfort, non-pharmacological comfort, things like birth tubs or showers or private rooms or even privacy in where you show up. That's a health system's, structural sort of deficit that is experienced as disrespect. The lack of option to the different types of providers, or someone who might be a culture matched or identity matched provider, that is accepted by people because they've lived and functioned in a world where they are marginalized because they're different, or they don't have people who understand them. But I think it is possible, and we have seen, certain communities around the world who really actively recruited and upskilled people who are culture matched. May start, like, say, with a culture matched doula. Doula might start with expanding admissions to medical schools or nursing schools or midwifery schools that really actively recruit Indigenous providers, for example.
Amazing ideas at the end there. Thank you.
I think the other thing is that we know that when we did our study, the respect study, we worked with community members to understand what those different domains of respect are. So that we have autonomy, respect. You asked about why were those needed. What we know is that we had for many years quality metrics, indicators of what would lead to well-being or not, that were very physical, like how much did she bleed? What was the APGAR score? What's their blood pressure? And we know that blood pressure or, certain medical conditions can adversely affect mothers and babies, parents and babies. What we didn't understand, and still are very nascent in understanding, is how that experience of care affects well-being. And it might be well-being at the moment. It might be well-being, later in life, like mental health or postpartum recovery, attachment, being able to parent. And those measures didn't exist, partly because they weren't prioritized as people would say, well, it's important to be nice to people, but we're saving lives, and not really understanding that the two things are inextricable. So once there started to be some more attention to this phenomena of respectful care, then we had to figure out how to measure it. And it is a concept that you can't just say, were you respected or not? What are you talking about then? Are you talking about, having to travel for care? Are you talking about someone having a poor interaction, someone mocking you or laughing at you, feeling discriminated against? Or are you talking about loss of autonomy, not being able to choose what you wanted? So there are many different domains. Some of them may be verbal, some of them may be experiential or structural. And so we identified these 12 domains first in a iterative process in conversation with a community steering council, and then with people who are providers and clinicians and people who are health systems planners and community advocate groups. We tried to get everybody in the room, the whole system in the room, to understand how to measure this in Canada. And understanding that these interactions, particularly the interactions when you're talking about between a person and the healthcare system or another person, a provider, or we wanted to be able to show what it looks like. So we started out, really a long time ago, in I think 2012 or so, we did the Change in Childbirth in BC study, which was a provincial study. And in that study, we still were nascent in understanding how to measure these things. So we worked with service users to go and find questions that had been asked before in a survey. So Listening to Mothers in the US had a number of questions about experience of care. And our community partners, who came from themselves different people who were newcomers to Canada, people with incarceration history, people with substance use history. They had unique experiences that really said you have to ask the questions, in the right way. And what does it look like? So is it about having enough time? Is it about being told that there are options for care? Either told the risks and benefits, having enough time to make that decision, whether your decision was respected, all those things, all of those 7 different ways of understanding what happened when you, say, were thinking about whether you had autonomy or whether or not you could choose. Those were all important questions. So we asked them in individual questions and realized that when you ask them together as a set, they then measure something, a construct or something like autonomy. It's a complex, you can't just do it with a single question. You have to be able to show the roundness of that interaction. So that's how we came up with the My Autonomy and Decision-Making Scale. We did a similar one around respect, which was about how comfortable you were to asking questions, accepting options, declining options, whether or not you felt like your cultural preferences were respected, whether or not you were treated differently because something in your identity, your resources, your sexual or personal or ethno-racial identity. And then whether those experiences affected how you showed up. Did you feel like you had to hold back your questions because you were going to be seen as being difficult because you wanted something different? Or did you feel like someone would feel you're too rushed? And so you just sort of kept quiet. We felt that was an important thing too, because it's not just how comfortable, we are in our interactions and whether or not we experience discrimination. And we don't ever use the word we perceived discrimination because people like me who are racialized, we know what's happening. And it's, we grow up with it. It's a lived experience. And I think by using the word perceived, there's sort of a question. Did it really happen or didn't it happen? Right? So our first commitment was we're doing what's called patient-reported experience measures. We're developing PREMs, and patient-reported is it happened. This is what happened to me, and that's a real thing. And then can we say, does that measure of autonomy or respect or mistreatment link to something else, either their identity or their outcomes? And so that's what we're unpacking now. We haven't really been able to say, we suspect from the disparities that exist in outcomes that this is part of the story. It's not the only story, but it's certainly part of the story.
Definitely. Thank you so much for taking the time to eloquently talk about the context of care, speaking to respect, or in most cases, disrespect that can lead to lack of options or not being heard, and that can lead to negative health outcomes that we are seeing. Thank you so much for kind of going into the story of the measurements of just, it's really, as you mentioned, really hard to just ask one question about autonomy. It has to be measure patients' experiences of autonomy and like that shared decision making, particularly in the field of maternal care and health. And yeah, I really appreciate you talking about patient-led development as well, of like a person's experience. They are experts of their experience, and having them in the room, particularly and the healthcare system as a whole in a room making these tools, is very wonderful to hear and very interesting going forward in the creation of tools going forward. Thank you so much for speaking towards that. Kind of shifting gears a little bit, your Giving Voice to Mother study found that Indigenous women were the most likely of all racial groups to report mistreatment during childbirth, followed by Black and Hispanic women. What is driving those patterns, and why are we seeing the same picture in Canada through respect?
Well, I think that's a question that should be obvious in the context of today's world. I'm fortunate to live in Canada where we still and are increasingly acknowledging the past, and when a dominant system believed that there was one right way to do things, and we are all living on stolen or unceded lands, and I would say that it's not for me to report. I'm really just a messenger, and I work alongside the Indigenous researchers on our team to tell the story of the multiple drivers for Indigenous families and racialized families, not just Black, but people who are brown and people who dress in their traditional ways that is not seen as the dominant culture here in Canada. I think you can't get away from talking about racism, and racism exists. But I think the racism again is not a individual interaction between, well, there are people who certainly that have implicit bias or make assumptions and don't even realize they're making a identity-based assumption. They are, they're, for example, people who are taught in medical school about, if for a while we had a calculator that suggested that Black race, they should lose points on whether or not they were more likely to succeed in having a vaginal birth after cesarean. And, my colleague, Dr. Rubashkin, has pointed out that this is sort of automating racism because there's nothing about your melanin, which is skin deep, that leads to your ability to give birth after a cesarean. It is more about the other factors. So do Indigenous and Black and racialized people in North America have the intersectional identities and structural factors that lead to poorer outcomes or adverse outcomes? Or what we have found, and sadly, in the US, when we disaggregated, when we separated things, or we combined even things like income. So you could be making less than $20,000 a year or more than $160,000, be a highly professional person, and you would have the same level of autonomy, which would be lower than the rest of the population. So it's clearly not just about income, and it's clearly not just about education or social standing. There's something else going on there. And I think when I again use the word us, I think we as part of the system, and that includes people who are racialized providers who have also been socialized in the same system, need to think more deeply about what's going on. What are our assumptions? How do we listen to people? Are we listening? It's almost like knowing a different language. Are we trustworthy enough that we will hear and that people will share the stories of their lives and the stresses that that can impact their well-being, or their access to outcomes, or are we listening enough? I think there's a lot of unlearning and a lot of self-reflection that needs to happen. But I think these are difficult skills when you've been, brought up in a system where there's a protocol, there is a pathway, there's a algorithm that helps you decide, what to do in a certain situation. And it's based, and it was structured by a system that looked at individuals, or maybe not even individuals, body parts and organ systems, and didn't really have that sort of whole person look or ask for or listen to other ways of seeking health. And that's what our community members say, is we can't just ask us, did you need mental health supports or smoking cessation or housing? What about, did anybody help us get that? Who's helping us survive and succeed and thrive? And that you can then, once you understand the positive, effects. And that's why in our research and other research, really globally, a lot of times midwifery care is associated with that sort of holistic, informed choice approach. Now, which isn't to say, in our own research, we definitely find that midwives, registered midwives, and are often within a system that either doesn't allow them to function through their full model, or where they also are following protocols that may or may not make sense to the individual. And so it's not really about doctor versus nurse versus midwife. We find nurses' interactions are the most troublesome. And that is I think in part also a structural thing because nurses are, I'm a nurse, I'm a nurse midwife from by training. And I would say, as I was trained and continues to be, is that we are trained to follow a certain protocol, that there's a right way, a wrong way, that you refer them in this situation. And this, and our ability to facilitate somebody's autonomy when they want to do something that's outside the guidelines is also reduced because we're not in that power structure, right, as nurses. So I happen to be a midwife also, and in midwifery we haven't, not only are we educated along this collaborative informed choice model, we have more time in the Canadian system to enact that informed choice. So it's not, again, it's not that doctors don't want to be in relationship. Family doctors, certainly that's part of their model. It's not that doctors don't, respect people's autonomy or want to do that. They just aren't given enough time to unpack those complex discussions. What kind of information do you want? Who makes the decisions in your family? You have to make a decision. Here are your options. Here are the risks and benefits of these different options. Can we pause and let you consider those options? Do you have enough time to reflect? Do you understand anything in what I just said? Can you reflect it back to me? And then can we come back and co-create a plan that fits for you, who you are as a person or as a family or as a community? That all takes time, and it may be a time in a single visit or maybe time over time, but then you have to have continuity too. You have to be able to see the same person to continue that conversation. And the models of care and reimbursement structures for providers are not all the same in Canada or really anywhere in the world. And so you can't really blame benevolent people who go into, people don't go into they go into medicine because they want to do the right thing, and they also care about health, right? They want to. Many medical students and residents are very altruistic, but then if they are placed within a structure that they're hamstringed, they can't really provide the care that they want, and there aren't enough providers or enough time or enough resources, then everybody suffers. And then, doing things like taking time to pause and understand their cultural context and go and read some more about, what might be an alternative way to do these things. Or, that time is that time takes directly from your family and from your, what you're doing. So I think it means that we have to really start at the beginning, really very young, where people in elementary and kids in elementary and secondary school learn what their healthcare rights are, what the system should look like, what there are these different systems of learning so that, and I think Canada is doing that more and more, when in the curriculum we talk more about things like the Truth and Reconciliation Act, we acknowledge, the existence and the horrors of residential schools and separation. When they grow up with that understanding, they're more, I think, more receptive to approaching and learning a different way. And then I think at the professional education level, we need to think a little bit more about who are the teachers. Do we have elders and knowledge keepers coming into the classroom? Are students being exposed to complementary medicines or other systems of thought around this? Are patients part of the teaching team, right? So there are lots of ways I think we could improve where we end up, and that will also affect then structures and payment, and if it's all about what the norm is, right?
Definitely. Thank you for such a fulsome answer. And I feel like anyone getting a chance to listen today, I feel like they'll have an understanding of like where we are now, and maybe get a chance to unlearn and look further into all the points that you discussed just a moment ago. Thank you so much. Going back to your study, the Giving Voice to Mothers, it was really interesting to hear like the key finding that mistreatment is not randomly distributed. It's patterned by race, care setting, and societal factors. And when you brought up SCS, it was really interesting as there's a lot of research coming out that SDS may not be as much as a protective factor as previously hypothesized in past literature. So I thank you for kind of speaking towards that. I think that's always really fun to see more and more papers coming about that. And yeah, just the unlearning and how people are brought up in a system, but there are hopefully there are more chances now from a very young age in education and learning that can lead to some of this unlearning and this maybe the system is becoming unstructured and maybe a little bit more equitable going forward. Thank you so much.
I think
You're
that, it'd be great if learning how to play well in the sandbox together, interprofessional, when we may come up from different philosophical approaches and education systems even now, but we can, if there are skill sets to be as far as how we reframe things, if we keep the person at the center of all of our decision making and collaborate to do that, and that's that's the gold standard, our North Star, then I think we can learn to be in conversation with each other and let people, when you ask them what they want to, really in every one of our studies, over 90% of people, some in Canada, it's 95% of people who will say they want to lead the decision. And only about a third of those people will say they want the input of their providers. So we kind of
mm,
aggrandize ourselves a little bit where we think we've got the solution, we know what to do, we'll tell you. And yeah, so again, I think having enough time during prenatal appointments, having a diversity of providers, types of providers, and backgrounds of providers, prioritizing, diversifying the professions, um, having there be a link between the structures, like how clinics are organized, and can you have evening clinics, can you have weekend clinics for people who have the kinds of jobs where they can't just take off and go for an appointment, or maybe their partner doesn't, so that their partner could come and could drive them if they came on a weekend or an evening. Can we do more community-based care, make it closer to home? Can we ask people when they're late to an appointment, is there anything we can do to help you? Bus vouchers you know, or ways to help people get to care. And I think if these are the things we do a lot, we do well with routinizing things like screening. But when we routinize things like screening, prenatal screening, or genetic screening, or ultrasounds, it becomes, oh, it's time for that. And then it takes away that moment where you can actually say, do I want this, or do I not? Does it fit
mm,
with who I am, or what's right? So it makes the system more efficient, but it reduces opportunities for autonomy decisions.
mhm,
And similarly, if everybody had to take a person-centered decision-making course every 5 years, just like we have to do neonatal resuscitation or hand washing, so these are skills we have to keep relearning and keep thinking and keep reflecting, and our understanding, like our understanding of gender inclusive language has changed a lot, even in the last 5 years, 10 years. And so we have to, it is a continuing competency that I think we all have to commit to, and it's as important as those medication reconciliation courses.
definitely. I think that kind of frames kind of beautifully into my next question is that you frame bodily autonomy as a safety issue if that's not considered into take in a medical setting. So, what does the evidence show about what happens to short and long-term well-being when people lose bodily autonomy during a healthcare encounter?
Yeah, it may be bodily autonomy, or maybe more like decisional autonomy, which
Mm,
aren't always the same. Um, so yes, if they can't, say yes to, we know from the Me Too movement that, it's this, you should have the right to say no, and you should be able to say, I accept an exam or not, and we should know who's doing that. Sometimes it's as simple as somebody walking in the room and introducing themselves. I
mm,
work with one colleague who's a physician who's a quality improvement leader in the US, and she describes how in their hospitals they have a commit to sit mandate for every provider, so that everybody gets sort of, they're rushing around, and they're coming in and they're out consult, and they just come in and pick up the chart and are looking at it and they haven't even like introduced themselves, right? And so their commit to sit is really, it doesn't take a lot of time. It's like walk in, introduce yourself, sit down. And just by sitting down, you slow down that moment, right? Sit down, and the first question is, why are you here today? What can we do? What would you most likely to do? You start the conversation there, and then it can go elsewhere. So I think there are very simple things that we can do within the structures we already have to improve experience of care and quality of care and people's sense of respect. When that happens, people don't feel like something was missing. I'm regretting what happened. We know that people, it's not about the intervention itself. Like people can have a cesarean or not have a cesarean. Some people end up having, mental sort of traumatic experiences when you have an unplanned cesarean, and others don't because they feel like they were fully involved in the decision making all the way through. And it's absolutely been linked to mental health, PTSD, sense of efficacy, feel sense of the competency, like my body worked. I knew I was part of this, and it's not about me. It was a sort of a luck of the draw, but that doesn't mean that I can't be a great parent, mother, breastfeeder, chest feeder. So it links to then the infant well-being too, right? If the parent is mentally well and stable and can care for that infant, stay up every night. So it has wide-ranging consequences. And also, we've shown that as I've said before, people will make different choices about whether they access care, who they access care from, delays to care sometimes can be then affected, and then also whether or not they're going to have another child, right? Whether or not they're going to expand their family, and that is has become a source of concern in some countries.
Mhm. Thank you so much for diving into those simple tasks that practitioners can do in pre-existing structures that we inhabit when allowing people to feel like they have autonomy and decision-making ability in the healthcare setting. I think that's really important. And also just it's can be very simple to start with. I think a lot of people might think it's a lot more heavy and might be a little bit more complicated, but I really appreciate you bringing those examples and very much highlighting person-centered care, kind of recognizing the full humanity and autonomy and knowledge that an individual has.
Yeah,
Not
I
just
like that word humanity, like recognizing someone else's humanity. That's where it starts.
our webinar asks what providers' responsibility to gauge in anti-oppression theory put into action looks like. So for nurses or midwiferys or doctors listening today who believes they care about equity, what does actually acting on that belief require of them?
Well, I think there are a lot of resources out there. There's um, a lovely 1 hour course called Structures and Self, where a um, perinatologist, obstetrician who is um, created one for people to look at themselves and they're within the maternity care cycle about how it's called Structures and Self, and it is accessible through UCSF. I think the National Council of Indigenous Midwives has a lot of resources on what their model of care, what the model of care that is common to Indigenous communities, and there are, of course, many different Indigenous communities. What does that look like? What does community-based care look like? Sort of unlearning means also relearning how it could be different. Um, so, accessing that, you may not go in. I've been fortunate in my career to look after a number of different communities, and some of those communities are not communities I grew up in. The Hmong community, the Orthodox Jewish community, the Orthodox Christian community. The common denominator was that they all wanted to have a community-based birth, and I was the only one in the state where I was practicing then that I could offer them. So I was invited into people's homes and lives and learned what was important to them, what their traditions were. And I think you have to know, not assume that the way you're going to do it, whether or not, you always draw blood, for example, and that is not something that will work in the Hmong community, or, whether or not you expect to have certain lights on and it's the Sabbath, and in an Orthodox family, they can't ask you to turn the lights on. And so you have to teach yourself and learn and ask the questions about how you can serve. Because I think in some ways that's what we've gotten away from, is that our professions are service professions. And so if we can ask what's important to that family in person and how they would normally do it in their family, and how you can again make the systems that we have work for them. In one of the hospitals I worked with, they only kept kosher. They only offered kosher fee on during the weekdays, not on the weekends. And Saturday
Mm.
was, the Sabbath, and it was really just completely crazy not to be able to eat, on that day. That's true in my culture. I'm vegetarian by culture, and very difficult sometimes to find adequate vegetarian food in institutions. So I think there are a lot of things, again, that the institutional structures could take responsibility for to make it easier. That would be true for interpreters, for example. What can we as a health system offer so that providers can learn and offer the best care, right? Can't do it without the system around you.
Definitely. It would be amiss to not consider the external environment that surrounds an individual or a workplace. We have to consider the institutions that surround that as well when trying to combat inequity and in the workplace as well. So thank you so
Mhm.
much for providing some. I'm going to make sure in the show notes we have those trainings you recommended. I know that the Respect Study also produced their own online courses as well. So going to put those as well in the show notes. Thank you so much.
Thank you. Yeah, we did we have some implementation tools, and we're constantly learning about what other people are doing. And I think if we had them all in one repository, because they're there. People are, and it's not all about showing up for an anti-racism 1 hour session, right? This is a long-term thing, but it's working together to
Mhm.
dismantle the systems that oppress.
Thank you. Yes, constantly unlearning and relearning. Thank you. You've built tools now that are used in 64 countries, led national studies, and you received a Lifetime Visionary Award. And you're still naming structural racism and obstetric violence as urgent problems. To kind of see that more positive side of things, what gives you hope? And where can people engage with your work?
Thank you for that question. I mean, you have to just show up every day, right? Leave aside the field that we're in. I have, you know, our family has experienced the, severe consequences of exclusionary policies around immigration, and around, wrongful incarceration. So that it doesn't really matter if it's in healthcare or not. I think wherever you show up in your life, if we don't uh, stand up ourselves, then these restrictive and oppressive systems will prevail and will continue. And I think we've seen that throughout the system. It's really difficult. Sometimes it's difficult to get up in the day and say, oh, for me, I'm like, well, I've been talking about this for 40 years. Why am I still talking about it?
Mhm.
But what I see in my own children and in my students and the next generation is that some of those things are not a new idea for them. They're already committed to it. They're eager to be part of the solution. And I do feel like things like the Truth and Reconciliation Act is a wonderful first step. We need to see implementation. We need to have accountability. Um, but I do think that also uh, people from historically marginalized communities are their voices, whether it's because of the internet age or because of an environment that doesn't criminalize them, we hear their voices more. And that also is a good thing. It's not true. And we know that in some countries in the world, those voices are suppressed, whether it be, you know, gendered, suppression, or you know, newcomers, immigrant, refugees, or racial groups that are being disenfranchised. But I think we in Canada have an opportunity because that trend has not come here. And I think we have an opportunity to model for acknowledge what we've done in the past and show how we can move forward in a good way, which is what the elders always, say to us. How can we do things in a good way?
Absolutely. It's time to start putting some action towards truth and reconciliation and making sure that exclusionary policies and standing up for what we believe is right for everybody. Thank you so much, Dr. Vedam.
Thank you.
Was there anything else that we might have missed in our conversation today or that you would like to add on?
I do want to acknowledge that I have been the beneficiary of teachings and learnings and collaboration of several Indigenous researchers. I will name them as Wanda Phillips Beck, Rachel Olson, Brittany Bingham, Jennifer Leeson. There are a number of amazing Karen Lawford. You can name them. There are very few, but they're huge in their impact in what they're doing. And there are also elders. Elder Roberta Price has been always walked by my lab. And I think their generosity in teaching me and teaching my trainees and their leadership in saying, yeah, it can be done a different way. I think that's true also in the Black community. They've had many amazing colleagues who have taught me and for a long time I was the only brown face, for years and years and years, every time I went to a professional conference. And it's exciting for me to see many more South Asian midwives and coming forth and researchers. So I think I have some hope there, and I want to acknowledge that I don't do this work alone.
Thank you for being one of the movers and shakers that gives us hope at AVA as well. Thank you so much.
Thank you.
Thank you for tuning in to the Her Health podcast, transforming health for women and girls at risk. Let's transform health together. Until next time, remember to prioritize your health and well-being.